Professor, just to confirm, were you able to like have the exam open for the week with respondus?
Yes.
Okay.
Over all the details, when we're finished in regards to when the exam opens and when it closes. But yes, I was able to do it in respondus, and it'll be open for the week.
Cool. Thank you so much.
You're welcome. Okay, so here we go. But it's not recording. I'm not sure why this does this. So let's start it. And here we go. All right, so immunosuppressants. Just a couple of things. Just standout things about immunosuppressants. When we use immunosuppressants, it's almost always used in conjunction with glucocorticoids to suppress the immune system to prevent rejection of organs such as liver, kidney, and the heart. There are some that are just approved for kidney only, like Rapamune, and then there's some that are approved for liver, kidney, and heart. And we'll talk about, for example, like cyclosporin. So we'll talk about them individually, the major ones. So immunosuppressants, they inhibit the immune response, and in the end, all in all, it's just interfering with the actions of B cells and T cells, and they do this via different mechanisms, but in the end, it's just immunosuppression by inhibiting the actions of B and T cells. They're used to prevent organ rejection and sometimes in the treatment of autoimmune diseases. The biggest side effects with these immunosuppressants, as you might imagine, by inhibiting the immune system and by interfering with the function of our immune response, it increases the risk of infection, which is a major side effect of these drugs. They're infection prone, and oftentimes patients may require prophylaxis with things like antifungal for fungal infections, prophylaxis for PCP pneumonia, if they have a history of latent viruses like CMV that wouldn't ordinarily cause a problem in somebody with an intact immune system. They may need to be on antivirals. They are put on prophylaxis for viruses, for bacteria, and for fungus because of their decreased immunity. And of course, when we interfere with the actions of the T cells, it increases the risk of neoplasms, lymphomas. So calcineurin inhibitors, the principal use is prevention of organ rejection in transplant recipients. And these are drugs called cyclosporin, tacrolimus, pimecrolimus, and these are the most effective immunosuppressants that are available. Cyclosporin is the prototypical drug in this category. It's been out for many decades, and it was the one that was first developed, and it's used more often. But since then, there have been other drugs that have been developed to treat transplant or prevention of transplant rejection that are employed more often than cyclosporin. But it's still pretty much in use, like tacrolimus is employed often. And all of these drugs, when we administer these drugs, it requires trough level monitoring that is drawn just before the next dose is due. So these drugs, they differ in structure, but they share the same mechanism, which is inhibition of calcineurin that suppresses the production of interleukin. And that's the bottom line. Calcineurin is responsible for activating T cells, and by inhibiting the action of calcineurin, it interferes with the activation of T cells. Cyclosporin was developed first and is used more than tacrolimus. That's changed over the past years. Cyclosporin is still used quite often, but you also see tacrolimus used very much, so it's probably surpassed cyclosporin in its use. So cyclosporin is known as Sandimmune, and this is a drug that is given orally or intravenously. Oral administration is preferred because of toxicity. So it works against suppressing the production of interleukin-2 and other cytokines, and it's used as a drug of choice for organ rejection in kidney, liver, and heart of an allogeneic transplant, meaning coming from somebody else or somewhere else. And it's used also in some autoimmune diseases. So again, in terms of pharmacokinetics, it can be given orally, it can be given IV. It's oftentimes it's given orally if a patient can tolerate the drug orally, and reserved for IV for patient is, for example, in a coma or under anesthesia, then it'll be given intravenously. Now, the thing about cyclosporin, it has multiple drug-drug interactions. The drug is highly protein bound. About 90% of the drug is bound to protein, and it is metabolized by CYP enzymes. And hence, by me saying that, you know that drugs that interfere with the CYP enzymes in terms of inducing or inhibiting them will cause interference with cyclosporin and other drugs. So, for example, this drug, if we have a drug that will induce CYP enzymes, it will metabolize cyclosporin faster. If we have a drug that inhibits CYP enzymes, it can cause cyclosporin toxicity. Adverse effects, the very common adverse effects, and happens almost in 3/4 of patients that take this drug, is nephrotoxicity. Infection is also a big concern in these patients, and hence we need monitoring of liver function, monitoring of kidney function on a regular basis when these patients are on cyclosporin. Another thing that you'll see with these patients is that the blood pressure goes up. There's a risk of lymphoma due to the immunosuppression, hepatotoxicity, because it's metabolized by the liver, and something that's common among many of these anti-suppressant drugs or these immunosuppressant drugs, tremoring. Now, and then there are other less common clinical manifestations like gynecomastia and sinusitis. It causes leukopenia, which would make sense. And then there's a chance of anaphylactic reaction. And of course, we have to monitor the patient for any signs and symptoms of anaphylaxis. It doesn't really happen that often, and it usually occurs with cyclosporin when it's given intravenously. Drug and food interactions, grapefruit juice. All right, we know that grapefruit juice has an interaction with drugs that are metabolized by CYP enzymes. In terms of, so drugs that can decrease cyclosporin levels will be drugs that are CYP inducers. And we know the common CYP inducers as the seizure drugs, right, such as phenobarbital and carbamazepine, St. John's wort, phenytoin. These are all CYP inducers and can lower the levels of cyclosporin. And then drugs that can increase the levels will be drugs that will inhibit CYP enzymes like ketoconazole, a lot of the azole antifungals as a group. So sometimes what you'll see is to decrease the costs of administering the drug to patients, it's been done where a patient will be intentionally given ketoconazole to significantly decrease the amount of cyclosporin, hence decreasing the risk of nephrotoxicity and hepatotoxicity, to get them down to increase the levels of the drug so that the patient's dosage can be reduced and the cost to the patient can be reduced. And ketoconazole can increase the amount of cyclosporin by as much as 90%. Of course, nephrotoxic agents will have an intensifying effect on the nephrotoxicity of the drug itself, and grapefruit juice will inhibit the metabolism of cyclosporin, and it will cause the levels to rise. Repaglinide, we know, is a glycinide oral anti-diabetic agent. Cyclosporin levels can increase repaglinide, leading to a patient with diabetes who takes the drug getting hypoglycemia. Tacrolimus is another. Don't forget, we have to monitor levels. We have to monitor cyclosporin levels, and we have to monitor trough levels. And dosing is based on those levels. Dosing is also based on the patient's kidney function as well. Tacrolimus, also known as Prograf, is an alternative to cyclosporin. It's a newer drug, and it's a first-line agent in treating patients who have transplanted organs. The drug is also known as FK506, and it's thought to be more effective than cyclosporin, but it's also more toxic. It has a very narrow therapeutic index, and it's used just like cyclosporin concurrently with glucocorticoids, as well as other immune modulating drugs like a drug called mycophenolate or azathioprine, which we're going to talk about in a little bit. So the therapeutic use is for prophylaxis of organ rejection, liver, kidney, or heart. And again, this drug, it interferes with it inhibits calcineurin that in effect would prevent the activation of T cells, and hence prevent immune responders like interleukin 2 from being synthesized. Adverse effects, again, another major adverse effect is nephrotoxicity. Additionally, this drug has neurotoxicity. Patients can become tremorous, they get difficulty sleeping, and they get headaches. GI effects are common. Patients can get diarrhea, nausea, vomiting, and again, they can develop hypertension as well as hyperkalemia. They can also get anaphylaxis when it's given intravenously. This drug also additionally can cause lymphomas as well. It's an immunosuppressant, so it can cause lymphoma, can lead to hyperglycemia, hirsutism, and again, gingival hyperplasia is a common side effect. There's commonality between the immunosuppressants with gingival hyperplasia. In terms of food and drug interactions, agents that inhibit CYP, grapefruit juice, and non-steroidals too with cyclosporin because of the effects on the kidneys and inhibiting prostaglandin. And so together, if you give non-steroidals with tacrolimus or cyclosporin, it can increase the risk of nephrotoxicity. Sirolimus or Rapamune is used only for the prevention of renal transplant rejection. It's used in conjunction with cyclosporin as well as steroids. Again, adverse effects, increased risk of infection. It raises the levels of cholesterol and triglycerides, risk of nephrotoxicity. The drug can also cause hypokalemia as opposed to Prograf and Sandimune. And it can have skin eruptions as well. Now, again, many of these, the nephrotoxicity increases too. What can further make patients or increase the risk of nephrotoxicity is having this latent virus called BK virus that patients can have and never know they have unless they went on immunosuppressants. But it's latent. It doesn't cause any problems. You get exposed to it, they get cold-like symptoms, and that's the end of it. But if you get these immunosuppressants and you have a latent BK virus infection, you can get what's called BK associated nephropathy. And this is concern when these patients have to take these drugs. Additionally, PCP pneumonia is a concern, so patients get prophylaxed for PCP pneumonia when they're taking these drugs as well. Again, this is a drug that requires trough level monitoring in order to prevent toxicity and to determine the proper dosage. And because of its effects on lipids, patients may require anti-lipid therapy. All right, of course, again, it has liver complications as well and lung complications. Again, drug and food interactions, drugs and inhibitor-induced CYP, high-fat foods, and grapefruit juice. Grapefruit juice, don't forget, most of the times when we see grapefruit juice, it's going to cause levels of the drugs to rise. Not most of the times, when if it's a CYP inhibiting, CYP inhibiting effect will raise levels of the drug, and high-fat foods can increase the absorption of sirolimus moderately, and hence can risk toxicity if if the patient's intake of high-fat foods is high. Glucocorticoids, we're going to cover those in the later chapters, used widely. However, in patients who have organ transplantation, they're on corticoids, and we have to teach these patients these are drugs that they will be on lifelong. It's not they will never be able to get off of immunosuppressants, because if the minute they get off of it, even if their levels get low, there's even on the immunosuppressants, there's still a risk of organ rejection, and so we have to teach our patients about the side effects of these drugs and implement ways to prevent the long-term side effects of these drugs. Like corticoids, we have to increase the calcium and the vitamin D in the diet, because they're the risk of osteoporosis when they're on this drug long-term. We have to give them proton pump inhibitors to prevent gastric ulcers. And so it's just a matter of giving them more drugs to control the long-term effects due to the chronic use of the corticoids. The glucocorticoids are employed along with the immunosuppressants for further immune suppression, and it's used for, as you know, for a number of different corticoids, used for a lot of things. But in this case, it's used to help augment the effects of the immunosuppressants by reducing the production of interleukin-2 by the lymphocytes. Large doses are used to prevent rejection. So when I say large doses, these patients are getting large doses there. They're getting, for example, I'll give you an example. A patient comes in for asthma exacerbation. They may get 60 milligrams of solumedrol, methylprednisolone, and they may get a total of 6 times 3, 180 milligrams per day. People who are acutely rejecting, or people who are immediately post-transplant, they may get as much as 1,500 milligrams of glucocorticoids per day to prevent organ rejection. Well, I think I mentioned this to you before. One of the side effects of giving a patient such high dosage of, among many others, but one of the things that you will notice that's very noticeable is the change in the patient's personality. When you give somebody that much steroids, they go from the nicest person to being just they get aggressive. They just have a whole personality change, and they can get psychosis as a result of the high dose. And when I used to work in transplant, the patients, prior to transplant, they were like the nicest people ever. And then after transplant, there's high dose steroids. It's like you can't even take it personal because you know it's the steroids and it's not them. So, but yeah, large doses are used to prevent rejection, and hence there's an increased risk of infection because of the increased immunosuppression. And long term, it causes bone marrow, bone osteoporosis, bone demineralization. Patients get pathologic fractures. In children, they get impaired growth, but they catch up as an adult. They get, of course, adrenal suppression. They get thinning of the skin, poor wound healing, high blood sugars. In addition to the fact that cyclosporin, will raise the blood sugars as well, and as well as the tacrolimus. So together, the patient gets hyperglycemia. Cytotoxic drugs, they also are used to suppress the immune response by killing B and T lymphocytes undergoing proliferation. Adverse effects, bone marrow suppression. It can lead to neutropenia and thrombocytopenia, leading to bleeding, leading to, of course, a decrease in the patient's immunity. Most common side effects are GI in nature. Patients can also suffer from hair loss and reduced fertility. So these patients, this drug is less used than the cyclosporin and the tacrolimus because they're safer immunosuppressants than this drug, and unless the patient absolutely needs to go on these cytotoxic agents, they won't be started on them. All right, so one of these drugs is azathioprine, which is Imuran. That's not to say you'll never see patients on these drugs, patients in the transplant arena. If you work in a transplant environment arena, you'll see patients taking azathioprine. And this drug, again, suppresses cell-mediated humoral immunity, the B-cell, T-cell function, and is used as adjuvant therapy in treating patients with transplant, meaning it's added on to standard therapy or added on to other drugs. It's also used in the treatment of other autoimmune diseases, and it's usually combined, again, with glucocorticoids. And you'll see it used for patients. It used to be used, for patients with heart transplant. Now you'll see it in patients with renal transplant. You see patients with rheumatoid arthritis. With patients with severe rheumatoid arthritis, you might see them on this drug as well. In terms of adverse effects, patients get neutropenia and thrombocytopenia. Those are the major adverse effects, and nausea and vomiting. The drugs, of course, are teratogenic, mutagenic. Hence, it can lead to development of cancer, and rarely it causes pancreatitis. Cyclophosphamide is an anti-cancer agent. It's used in the transplant arena for immunosuppressant. Is not one that is used very often, but when it is used, it's used to decrease the activity of B and T lymphocytes. Major adverse effects with cyclophosphamide is bone marrow suppression. Methotrexate is a drug that I want you to remember. It's an anti-cancer drug as well, and it is used to treat a number of different conditions such as psoriasis. It's the go-to drug to treat patients with rheumatoid arthritis. It suppresses B and T cell lymphocytes by interfering with folate metabolism. Hence, and it's a drug that's given and it's dosed weekly. Hence, when we're giving this drug, we have to give the patient a folic acid together with the drug to replace the folate. So methotrexate and folic acid together. Mitoxantrone it's also another cancer agent that's used for immunosuppression. It's not really used very often. So you're unlikely to be tested on this drug. Definitely, this drug will be somewhere on your boards, so be familiar with it. There's a hazardous drug that's reserved for patients who are not responsive to safer drugs. When you're dealing with these drugs, just make sure you're also handling them with gloves. Many of these drugs are cytotoxic in nature, and you don't want to get on your skin. Methotrexate is also a high alert drug because it can cause significant damage in patients when it's given in error. I was just watching a case the other day on. So I'm addicted to murder mysteries and such. So there's a girl who so she had a boyfriend, and the boyfriend's mom was a physician and hired her, and he got his girlfriend a job in his mom's office. And, being a nice boyfriend. The boyfriend broke up with her, and she was very angry with the boyfriend. So she decided she was going to poison the mom poison and kill the mom to get back at the boyfriend. So while she's working at this doctor's office, the whole time she was there, she learned, she saw colchicine prescribed for a patient, and she decided to look up what colchicine was. And she decided she was going to order colchicine. I think she got like a bulk dose of colchicine from Canada or somewhere shipped to her. She ordered it on her phone. And that's how they were able to track, how who got the colchicine after they did the autopsy on the mom. She ordered all this colchicine, and she poisoned the mom. She crushed the colchicine and she poisoned the mom. So the mom, the physician is working, and she gets sick on the job, and they had to call 911. Within 2 days, she was dead, and she was pretty healthy, no medical problems, not on any medications. And so when they did a whole, it was so odd that she got so sick so quickly. She was in the ICU right away, out of nowhere. And so they started, the medical examiner decided to check her blood for, the toxicology, and they checked, and they found colchicine in high levels in her blood. And it was the first time, they said, I don't know how true it is, but they said it was the first time someone had ever been poisoned with colchicine and not. So I just remember that because I was just thinking about methotrexate toxicity. But yeah, that's my story about colchicine. As you know, colchicine is a medication. It's anti-inflammatory. It's used for gout, and even to renal failure, which colchicine can do. They went to renal failure. She ended up on dialysis within a day. It was awful. All right, other cytotoxic agents. 1 second. Tyler, yes, it's a true story. It's a true story. I watch. I don't have a TV, so I watch some stuff on YouTube, and so I watch all these murder mysteries on YouTube when I multitask. I don't have time to watch anything. I should say I listen to it as I'm doing other stuff, like when I'm working, making exams, grading papers, whatever I'm doing. I listen to it. But yeah, it is. It's true crime. The YouTube series is called True Crime. Yeah. So you can actually, so that it's a thing. You can order stuff from Canada. You can order drugs from Canada if you can't afford it in America. You can do it right online, and you don't need a prescription. A lot of my patients who can't afford, this is an aside. I have to get back to the lecture, but one of my patients, he gets Viagra online because he can't afford it in the United States. So he didn't get it from online. He's a truck driver. He goes all the way up in upstate New York, and then he'd just go over there and get his Viagra and come back. And he'd get like loads of Viagra. And there are signs in doctors' offices now where patients can go to, I think it's called like CanadaDrugs.com, and order their insulin if they can't afford it here because it's very expensive. So insulin you can order. Insulin you don't even need a prescription. You just order it and they send it to you. It's pretty cheap. So yeah, lots of people now are ordering their drugs online from Canada and having it shipped here. So let's see. Okay, mycophenolate. Mycophenolate is approved for prophylaxis of organ rejection. It acts on B and T lymphocytes to inhibit inosine monophosphate dehydrogenase, which in the end just inactivates the T and B cells from producing cytokines. And it selectively inhibits B and T cell proliferation and hence decrease their activation and production of cytokines. Okay, so question one, after receiving an allograft liver transplant, the patient is prescribed cyclosporin, oral solution. What is the most critical component of patient teaching that the nurse should stress? A, the medication will help prevent transplant rejection. B, the oral solution can be mixed with orange juice. C, the medication will be taken every day for life. D, the medication causes reversible increase of hair growth. A, B, C, or D. So the right answer is C. The medication will be taken every day for life. A patient is prescribed sirolimus and cyclosporin after renal transplantation. It is most important for the nurse to closely monitor which value. A, serum creatinine. B, aspartate aminotransferase. C, serum potassium. B, partial thromboplastin time. A, B, C, or D. Major side effects of these drugs, two of them are prominent. So yes, Tyler is correct. A, yes, nephrotoxicity. Yes. So monitor the serum creatinine for nephrotoxicity. Remember, normal serum creatinine is about 0.6 to 1.2. Depending on the lab, some labs may be a little higher, but generally speaking, 0.8 to 1.2. And so you want to, anything higher than 1.2 would indicate that the patient is having some decline in kidney function. When caring for a 21-year-old female patient post-kidney transplant who's taken cyclosporin and repaglinide, what should the nurse do? So it's a little tricky question, I think. It's kind of like throws in a drug in there just to kind of like, make sure you know the interactions, basically. So A, administer the medication with grapefruit juice, monitor the patient for hyperglycemia, encourage the patient to take an oral contraceptive, assess the patient for signs and symptoms of infection. What is the correct answer? The correct answer is D, assess the patient for signs and symptoms of infection. Administer the medication with grapefruit juice would increase the levels of cyclosporin, monitor the patient for hypoglycemia because repaglinide is an oral anti-diabetic agent and it causes hypoglycemia by itself. But when it's given with cyclosporin can significantly increase the levels of repaglinide, so the patient has to be monitored for hypoglycemia. Encourage the patient to take an oral contraceptive. Well, there's nothing indicating the patient is asking for an oral contraceptive. So the biggest side effects with taking cyclosporin is nephrotoxicity and infection. And then, of course, right after that is development of neoplasms lymphoma. Any questions? Okay, let's move on to the next. Sure. 73, we're doing next. Drugs for RA. Okay. Okay, so rheumatoid arthritis, as you know, is an autoimmune inflammatory disorder that causes systemic inflammation, systemic inflammatory condition that causes symmetrical joint inflammation, joint pain, symmetrical joint deformities. And these patients, when they have RA, this is one of the things that they'll tell you is that they have intense joint pain in the morning and it gets better as the day goes on. And you look at them, the joints are swollen, and it's usually the smaller joints. And it's a condition that's chronic in nature. They get exacerbation and they get remission. So the treatment is to basically, we want to control the inflammatory response. So suppress the immune system, we want to relieve the symptoms, maintain joint function, minimize systemic involvement, delay the progression of the disease, so delay that pannus formation that occurs on the joint, and non-drug measures such as physical therapy and exercise. So there are a number of different drugs that we use to treat patients who have arthritis in general, and for those and different ones for patients who specifically have rheumatoid arthritis. And again, the goal is to provide symptom relief and to prevent disease progression. So the main drugs that are used for treatment of rheumatoid arthritis, they're the NSAIDs and non-steroidals, there are steroids, the glucocorticoids, and then the DMARDs, disease-modifying anti-rheumatic drugs. And under that category, there are a number of different drugs. And we'll talk about a few of them that you should be familiar with. So non-steroidal anti-inflammatory drugs, first generation NSAIDs, and they inhibit cyclooxygenase 1 and 2. So these would be things like, things like ibuprofen, naproxen, and then the second generation NSAIDs are the coxibs, and that's celecoxib. They selectively inhibit COX-2. They tend to have less GI irritation than the first generations. All prescription strength NSAIDs carry a box warning regarding risk of thrombotic events and GI ulceration and bleeding in patients who take the prescribed strength NSAIDs. Glucocorticoids, patients take it orally, or they can take it intra-articular. So when they take it orally, they get generalized symptoms, and we'll talk about those in a little bit in more detail. But biggest thing with glucocorticoids that you may be asked on your test is, taking it. Patients who are diabetics taking glucocorticoids can cause hyperglycemia, and they will increase their need for insulin. One or two joints that are affected, patients can go. They can get steroids injected right into the joint to help relieve the inflammation, as well as decrease the symptoms. Adverse effects, there's so many adverse effects. And it's associated with long-term use of the drug. So, patients gain weight, they get obesity, hypertension, hyperglycemia, poor skin healing, thin skin, striae over the abdomen, buffalo hump, fat redistribution. In children, it decreases, slows down the growth. In women, it can cause the voice to deepen and cause hirsutism, facial hair, moon face, nasty attitude. There are a lot of adverse effects associated with the use of corticoids. So these drugs, many of the steroid drugs, they end in ONE. So you have the prednisone, methylprednisolone, prednisolone. DMARDs, there are different types of DMARDs. The major non-biologic DMARDs are methotrexate and sulfasalazine. Now, methotrexate, again, is the one that is used more often because it works very fast. It's the most rapid acting DMARD that the patient that's used, and the patient will usually see a good response within a month or a little month and a half. Patients will start to see symptom relief. Most of the patients who we start on methotrexate will respond to methotrexate, and then the small percentage will require more intense modifying drugs. So methotrexate, very common drug used to suppress the immune system. They reduce the activity of B and T lymphocytes. It's the first choice drug for many patients who have rheumatoid arthritis, and it increases the risk of infection because it is a drug that is immunosuppressant in nature. It does have toxicities that we have to monitor for when we have patients on these drugs, and that's hepatic fibrosis. We have to monitor the patient's liver function. We have to do a CBC and check the patient's red blood cell count, white blood cell count, and platelets, because it causes bone marrow suppression. It leads to GI ulceration and pneumonitis, inflammation of the lungs. So patients require every 3 months to check their blood work to make sure that they have good liver function, good kidney function, and that they're not pancytopenic. The drug is a category X because it causes fetal death, and it also causes fetal congenital abnormalities and malformations. So it should not be given to a pregnant woman. And the drug has other risks involved with it, like lung cancer. It increases the risk of lung cancer, increases the risk of melanoma and non-Hodgkin lymphoma. And as I mentioned before, when we give patients methotrexate, they have to go on at least 5 milligrams of folic acid a week. We usually give them 1 milligram a day. All right, they have to be the folic acid. They go together because of the action of this drug. It interferes with the folic acid function in the cell. Sulfasalazine is a drug that is used. It's a DMARD that is used to treat inflammatory bowel disease, and it's now used for rheumatoid arthritis as well. Again, the drug is an anti-inflammatory immunosuppressant agent that slows the progression of joint deterioration. The drug does have serious GI, very, very common GI effects, nausea, vomiting, diarrhea, poor appetite. Patients again can start to see a response to this drug within a month or so. A patient with rheumatoid arthritis has been taking high-dose aspirin and complains of gastric upset and pain. What does the nurse anticipate will be prescribed for this patient? A, B, C, or D? A, B, C, or D? taking a lower dose of aspirin, biweekly injections of methotrexate. Methotrexate is once a week. Obtaining a prescription for celecoxib or daily drug therapy with prednisone. So Miguel Nicholas, you're right. It's C, obtaining a prescription for celecoxib, which this is a specific COX-2 inhibitor, and it tends to have less GI effects than aspirin that inhibits both COX-1 and COX-2. Prednisone prednisone, they can get it daily, but just for an exacerbation. It's not something that they're on every single day chronically when they have rheumatoid arthritis. If they have the need to be on that every day while they're on methotrexate, then they need another DMARD. But it is used for acute exacerbations of rheumatoid arthritis. A patient with rheumatoid arthritis is prescribed methotrexate. The nurse will expect to observe therapeutic effects with this drug in which time period? A, B, C, or D? Paul, Tyler, Jacqueline say B, and the correct answer is 3 to 6 weeks. Very quick. They may see responses in terms of their symptom relief starting steroids in 3 to 7 days, but in 3 to 6 weeks, they'll see the more long-term effects of the methotrexate. Any questions? Okay, so we're gonna move on to chapter 74, drug therapy for gout. Okay. Drug therapy for gout, as you know, gout is a recurrent chronic inflammatory disorder that is seen mostly in men and is characterized by hyperuricemia, where the patient gets uric acid depositing into the joint, leading to inflammation and destruction of the joint. And it can be due to excessive production of uric acid or impaired renal excretion of uric acid. So this is a condition where they can have hyperuricemia, where they have no symptoms whatsoever, or they can be stable, where they have intercritical gout, where they don't have any symptoms whatsoever, but they have high uric acid levels. They can have an acute gouty attack, where they're just exacerbated, and they have swollen joints, and then you give them some steroids or you give them some colchicine and they get better. And then they can have tophaceous gout, which is really start to have the uric acid crystals precipitating in the all over the body, in the skin and the eyes and the pin of the ear, and it's in the soft tissue. So when uric acid deposits into the joint, it causes this inflammatory response and destroys the joint. And as you know from our lecture last semester, one of the most common signs that these patients present with is left or right, great toe swelling. Great toe swelling, erythematous, and it's exquisitely tender. You can't even, if you try to put your finger near the toe, they jump. Patients jump because it's so painful. They can't wear a shoe or anything like that. All right. Causes, I told you that already. And short-term relief comes from using corticosteroids or NSAIDs, which are first-line agents. We can also use, for short-term relief, we can use colchicine, which is also anti-inflammatory in nature. By far, for acute gouty arthritis, meaning that they're having an attack, NSAIDs are first-line agents. Now, the reason why colchicine, which is very good as well at containing the inflammation, the reason why we go NSAIDs first is that patients tolerate NSAIDs better. So better tolerability. So we start, as soon as the patient senses that they're getting a gouty attack, they should start taking the prescription strength and NSAIDs, not Motrin, 100 milligrams or 200 milligrams. They require high dose NSAIDs, ibuprofen. Usually, if they catch it early enough and they don't let it go too far, usually patients will start to have symptom relief within 24 hours of starting the NSAIDs. Even with steroids, within 24 hours, the patient will feel better starting the steroids, and then it will subside. Like I'll give the patients, NSAIDs, colchicine, prednisone. They come back in a week, and the toe looks completely normal. They feel great. They don't have any more pain. The swelling is gone. They usually will have swelling, the complete relief of the symptoms usually within a week or so. The long-term aim of treating patients with gout is to lower the uric acid levels. And so we can give them, oh, by the way, this is one that seems to be used primarily in patients with, the NSAID that's used primarily in patients with gout is indomethacin. This is prescribed. Indomethacin. Before I forget, I just remembered, I was just lecturing yesterday, indomethacin, in the Newark group, and I started to tell them something, and then I'm like, I don't think I told the New Brunswick group this. Remind me when I'm done with my train of thought here. So the common drug that's used is indomethacin, and we can also use things like naproxen or diclofenac. These are all NSAIDs that are used frequently in managing an acute gouty attack. Of course, take it on a full stomach because it can cause gastric irritation. Same thing with the steroids. Now, in terms of lowering the uric acid levels, there are a number of different drugs we can use, and it falls under the category of uricosuric agents. So NSAIDs, agents of first choice for acute gouty arthritis, better tolerated and more predictable than colchicine. Relief should occur within 24 hours. Swelling subsides over the next few days. Adverse effects, GI. Take it with food to help decrease the GI symptoms. Of course, NSAIDs have an effect on the kidneys because it blocks prostaglandin and can lead to kidney failure, decreases perfusion of the kidneys, and so it can lead to renal dysfunction, fluid retention. Using NSAIDs promote the retention of sodium in the kidneys and hence water retention as well, and increased risk of cardiovascular events such as heart attack and stroke. All right, so indomethacin, very commonly used, also known as Indocin, naproxen, diclofenac. These are common NSAIDs that are used to treat acute gouty attack. Prednisone is highly effective in relieving pain. It's useful for patients who are hypersensitive to or unresponsive to or have medical conditions that contraindicate the use of NSAIDs. Avoiding patients who are prone to hyperglycemia, like diabetics. Colchicine. Colchicine as an anti-inflammatory agent is no longer the first-line agent owing to side effects. It's now reserved for patients who are unresponsive to or intolerant of safer agents and not effective against other anti-inflammatory disorders. Again, this drug can cause nephrotoxicity. It can cause significant myelosuppression. It can cause significant GI effects as well, nausea, vomiting, abdominal pain. And it's only used in patients with gout. You don't see this used for people with just regular arthritis like you would see naproxen used. It can cause rhabdomyolysis. Okay. What else? About colchicine, rhabdomyolysis. Oh, it has interactions with. It's metabolized by the liver, so it has interactions with CYP enzymes. Okay, so drugs that can increase the induce CYP enzymes will clear this drug out faster, and drugs that inhibit CYP enzymes will increase the levels of this drug. So, muscle breakdown, muscle damage increase when patients have underlying liver disease or kidney disease. Using caution with patients who have hematologic conditions because it can cause pancytopenia, bone marrow suppression. Those are like the big things with this drug. Now, in terms of drug interactions, they have an interaction with statins, and statins, as you know, causes myopathy, and this drug can also cause myopathy, and so the risk of myopathy is significantly increased when we give these two drugs together. Now, and of course, P-glycoprotein inhibitors will cause the levels of the drug to rise. Precautions and contraindications. Again, older people, debilitated people, they have underlying conditions, like they have decrease in kidney function, they have decrease in liver function oftentimes, and GI dysfunction, and so it can complicate or exacerbate those conditions. Should not be given in pregnancy. We know that pregnancy, when you give anti-inflammatories, for example, like NSAIDs, it's been linked to the development of, so NSAIDs, for example, will cause a decrease in, it causes premature closure of the ductus arteriosus, so we shouldn't give it to pregnant women. Never. And colchicine as well, we should not give it to people who are pregnant. Now, there's another form of colchicine. So colchicine itself is known as Colchris, that's the brand name. This drug, Colchris, is approved for acute gouty attacks, just in case you're wondering, because if you don't know, you wouldn't know. The difference, unless you were told. So Mitigare. Mitigare is this is colchicine as well, but this is only approved, Mitigare, MIT. This is only approved for chronic gout. So you wouldn't, like if I were to prescribe, somebody came in and they had an acute gouty attack, I wouldn't give them Mitigare, to treat their acute gouty attack. I would give them Colchris. And usually when we give Colchris, usually the daily dosage of Colchris is 0.6 milligrams, but when we give it for an acute gouty attack, we give 1.2 milligrams, and then we revert to the 0.6 the next few days. So goals of therapy is to promote dissolution of the uric crystals, prevent new crystal formation, prevent disease progression, reduce frequency of acute attacks, improve quality of life. All right, and so these are the drugs that decrease uric acid levels. Sorry, I didn't state that up front. These are drugs that decrease uric acid levels. So this is long-term chronic use. It's not, the drugs we just talked about, the NSAIDs and the steroids, those drugs are for acute gouty attack. These are the drugs that will prevent the patient from getting the gouty attacks and keeping them in that intercritical period of gout. All right, so these are the uricosuric agents. All right, so they don't prevent inflammation at all. They just prevent uric acid from building up in the body. So allopurinol is a very common one. It's the oldest one. It's the one that you'll see most often. It's the cheapest one. It's a prototypical agent for the urate lowering therapy. And we start these drugs in patients because they do have side effects. Like febuxostat can cause liver failure. Okay, we reserve these drugs for patients who have frequent gouty attacks. You know, we can teach our patients to cut back on the protein in your diet so that they can cut back on the uric acid, which is a byproduct of protein metabolism, and that may control their symptoms and prevent them from getting acute gouty attacks. But if they're having frequent acute gouty attacks, then we have to give these patients urate lowering therapy. And again, we want to prevent the patient from having high uric acid levels. And we monitor the uric acid levels while they're on therapy. Right, so these 5 drugs, 2, 3, 4. Well, there are 5 drugs, allopurinol. There's a new one on the market that's not. But the new one on the market is called Raz, which we probably won't get tested on, Rasburicase. But these 5 drugs are urate lowering drugs, and the goal is to decrease the uric acid levels. And they have different mechanisms of action. So this inhibits uric acid formation, this increases uric acid excretion, and this converts uric acid to allantoin, which is readily excreted by the kidneys. So allopurinol is probably one that you'll get tested on the boards. Reduces the levels of uric acid. This drug is what's known as a xanthine oxidase inhibitor. And there's the other one that is febuxostat. They're both, like one is not superior to the other, but allopurinol is cheaper because it's on the market longer. And it's been around for a longer time, so people tend to go for allopurinol before they do febuxostat. So allopurinol is the drug of choice for treating chronic tophaceous gout and hyperuricemia due to chemotherapy. As you probably remember, when a patient is undergoing chemotherapy due to the rapid the apoptosis of the large number of cancer cells, the byproduct of the cellular destruction is uric acid, and so patients tend to get hyperuricemia. And so oftentimes you'll see patients who are being treated for cancer on urate lowering therapy. So allopurinol is generally well tolerated. Patients can get a hypersensitivity syndrome. They get GI effects and they can get neurologic effects. Now, the drug, and that's all, again, dose dependent. We have to make sure that we dose the patients appropriately. If the patient's got decrease in liver function, we have to lower the dosage and hepatically dose the patient because the drug is metabolized by the liver. So other than that, patients usually don't complain about having any kind of issues with the drug. Sometimes they may get a rash. Sometimes they may end up with an increase in the eosinophils, and it can also lead to rarely liver failure and kidney failure or dysfunction. So allopurinol is a current drug of choice for chronic tophaceous gout. It reduces blood uric acid, and it does so by inhibiting xanthine oxidase, which is an enzyme that's required for uric acid formation. It prevents new tophi from forming and causes regression of tophi that patients already have. And it allows for joint function improvement. Reversal of hyperuricemia also decreases the risk of nephropathy from deposition of urate in the kidneys. Other uses for allopurinol include hyperuricemia that develops secondary to cancer chemotherapy, and it can cause blood dyscrasias like polycythemia. I mean, it can treat use for certain blood dyscrasias like polycythemia vera, myeloid metaplasia, and leukemia. And again, it has to do with the uric acid production with the cell proliferation, and in the case of chemotherapy with the cellular destruction. Mechanism of action: inhibits xanthine oxidase, an enzyme required to cause the formation of uric acid. Adverse effects: rarely, but potentially fatal hypersensitivity syndrome. Now, the thing with allopurinol is that initial therapy may elicit an acute gouty attack, in which you'll see when we start patients on allopurinol, what we do is we put them on colchicine for the first 3 months to prevent an acute gouty attack. And then once they're past that 3-month period, while they're on these urate-lowering drugs, then we can stop the colchicine. Okay, so, and the reason we do that again is because once we start a therapy, patients are prone to an acute attack. So again, not much in the way of side effects. Patients generally have GI side effects. Interactions, they have, again, it's metabolized by the liver, so it has interactions with hepatic metabolizing enzymes. Febuxostat is known as Uloric. It reduces levels of uric acid in the blood. It's used for chronic tophaceous gout. Again, adverse effects are not that common, but liver dysfunction, patients can get liver failure from this drug. So we'll monitor the liver function test periodically. And then the next most common side effect is GI in nature, as I mentioned before. Sometimes these drugs may cause a rash, sometimes a fever, sometimes eosinophilia. Probenecid is a drug that's not used that often anymore, but this is a uricuric agent, and it increases the excretion of uric acid in the renal tubules. Adverse effects is generally well tolerated, but again, GI effects are usual. So this drug can also cause hypersensitivity reactions as well, and these patients, it starts with a rash. So because this drug works on getting rid of uric acid in the kidneys, there's going to be a lot of uric acid in the renal tubules. It can lead to deposition of urate in the kidneys, and hence it causes the risk of kidney damage and renal failure as a result. And so to minimize this, we can alkalinize the urine and have the patient increase the amount of fluids that they're drinking up to 3 liters per day during the first 3 days of treatment. In terms of drug-drug interactions, salicylates and aspirin is salicylate. So salicylates, they can block the action of the drug. So it decreases the effectiveness of the drug. Pegloticase is a drug that is a recombinant form of uric acid oxidase, and it's a drug that is given intravenously for patients who have refractory gout. And so they've exhausted all possible treatments, and then if that doesn't work, then we go to the recombinant form of uric acid oxidase formula. So it's a last resort. Again, when we start these drugs, there's a risk of gout flare-up, infusion reactions, anaphylactic reactions. Question 1. Patient with acute gouty arthritis requests information on the preferred drug to take to treat a painful flare-up. The nurse should recommend which medication, A, B, C, or D. So the correct answer is patient with acute gouty attack. They request information on preferred drug to take. So what's the preferred drug to take for an acute gouty attack? An NSAID, right? So the only NSAID on here is naproxen. Hypersensitivity. Don't forget. I think Tyler asked what's the difference between a hypersensitivity syndrome and a anaphylaxis. Hypersensitivity, anaphylaxis is the extreme of a hypersensitivity reaction. So a hypersensitivity syndrome with patients would show signs that they have an allergic reaction to the drug or have an immune response, not necessarily an immune response to the drug, but it may not be, it wouldn't rise to the level of anaphylaxis. So they'll have the itching, they may have the swelling, but it doesn't get to the point where they can't breathe and they get laryngeal spasming and hypotension. Patient is prescribed allopurinol, chronic tophaceous gout. The patient develops a rash. What is the priority intervention by the nurse? Yeah, it would sound like it's something chronic, right? But no. Right, remember we talked with ARDS, acute respiratory distress syndrome? That's not necessarily something that is chronic in nature, right? But it's a syndrome. A syndrome just means a whole bunch of clinical manifestations together that speaks to a condition. The correct answer here is A, B, C, or D. Patient is developing a rash. So the correct answer is stop the medication, assess the patient for liver and kidney failure, instruct the patient to avoid exposure to this element. We want to stop the drug. The patient. It looks like they're developing a hypersensitivity syndrome, which can lead to liver and kidney failure. A patient with gout has not experienced relief with conventional drug therapy. The nurse anticipates which agent will be prescribed to work with the patient, A, B, C, or D. Which is used for refractory gout? Pegloticase. Yes, A again. Any questions? Okay, let's move on to '70. Drugs affecting calcium levels and bone mineralization, and this speaks to the treatment of osteoporosis. Can you guys hear me? Oh, yes.
That was good.
Kelsey didn't miss it, and see, I already forgot. So Kelsey just reminded me that something I took yesterday. I was lecturing because they're a week behind you, and well, yeah, they're I think a week.
You were looking at slide 3 on the gouty of gout.
Okay, thank you. I happened to remember it on that slide, but it had nothing to do with anything on that slide, and it was metformin. Which, just be aware that this might be in your test. Metformin. A couple of things about metformin that I didn't tell you. I already forgot. Oh my God. The first thing is, contrast dye. Contrast dye. If a patient is taking metformin and they have to go for like a CAT scan of the whatever, and they need contrast with the CAT scan, or they are going for cardiac catheterization, they need any kind of contrast iodinated dye. The metformin, they cannot go until the metformin is held for 48 hours. All right? If it's not held for 48 hours, there's an increased risk of lactic acidosis. This is a board question. And what we also do to prevent the lactic acidosis is also once they're on the metformin, once we stop the metformin, we also will, if they can get it, put them in IV fluids before the contrast and after the contrast dye, because IV fluids to flush the kidneys out to prevent contrast, induced nephropathy. So the biggest thing though with metformin and not holding it 48 hours before, 48 hours after is increasing the risk of lactic acidosis, particularly if they have even the most minor renal dysfunction. That's the one thing about metformin. Let me see, I think I made a note to myself. Oh, and then the other thing that I forgot to tell you guys, so that's metformin. Contrast, any contrast procedure, hold metformin 48 hours before and afterwards. And then high levels of TSH. I forgot to tell you this because this is something that, it's on the slide, but I didn't emphasize it in your text, but I didn't emphasize it. But I want to emphasize it. When a patient comes into the hospital and they have atrial fibrillation, one of the first things that we check is a TSH level, because high levels of TSH can lead to a number of different dysrhythmias, but AFib, it can lead to atrial fibrillation, and even overdosing a patient on levothyroxine can lead to patient developing AFib. Okay, so just remember that. So that's it. That's all I wanted to. Thank you for reminding me, Chelsea.
Can you just say one more time? It's increased TSH leads to AFib, not
Sorry.
AFib leads to increased TSH, right?
No. I just messed it all up. Increased T3. I'm glad you asked because I just messed it all up. Increased thyroid hormone, T3 and T4. Lord have mercy. It's all this revving in the background here just got me. Increased thyroid hormone, increased thyroxine. All right. Increased thyroid hormones lead to a hyperthyroid state, and it leads to development of dysrhythmias, including atrial fibrillation. So one of the first things that we check when a patient comes into the hospital when they have AFib, we do check a TSH, all right, to see if the patient has hyperthyroidism, and depending on the reason why they have the hyperthyroidism, will determine if this is high or low. But if a patient has primary hyperthyroidism, TSH will be very low. TSH will be very low. So they'll get suppressed TSH with primary hyperthyroidism. TSH will be low, and T3 and T4 will be really, really high. Does that clear it up?
Yes, thank you.
Okay, thank you for reorienting me and asking the question. All right, so that's that. All right. Osteoporosis. As you know, osteoporosis is a condition that affects a number of different people. We most often see it in women who are postmenopausal. Do we treat them with something else for diabetes during that time when you can't get metformin? Well, Gabriella, yes. I mean, so metformin doesn't really affect the blood sugar that much, right? So it's not going to cause your blood sugar to spike. Like if you stopped glyburide or glipizide, for example, which is a sulfonylurea, If you stop that, you see the blood sugar spike. But if you stop metformin, you won't really see a huge spike in the blood sugar. But if they do, even for a few days, yeah. But if they do spike, every person who comes into the hospital who has diabetes, they always get like a standing order of insulin sliding scale for any blood sugars greater than 150. So, but yeah, taking a patient off metformin for a few days won't really cause a spike in their sugar short term. If they, maybe after weeks of being off of it, then you would see the A1C go up, but it won't cause a huge spike in the sugar. Now, yeah, but the other drugs like the gliptins and the sulfonylureas that that beat insulin out of the pancreas, yes, you'll see a spike in the sugar. Okay, no problem. All right, so bisphosphonates. So osteoporosis affects postmenopausal women due to the decrease in estrogen. Men also can have osteoporosis, and people who use long-term glucocorticoids can get osteoporosis because it decreases calcium absorption from the GI tract. I'm sorry. So the bisphosphonates, these are drugs that are used to help remineralize the bone, and it decreases the osteoclastic activity within the bone and increase the osteoblastic activity of the bone and help the bone rebuild, preserves the bone. Well, and it's also done in conjunction with oral calcium and vitamin D as well. Now, as you know, we need active vitamin D in order to be able to adequately absorb calcium from the GI tract. So alendronate, Fosamax D plus D is the most widely used bisphosphonate, and this is one of the drugs that's used for bone demineralization. The drug has poor oral bioavailability, and in terms of adverse effects for your boards, you need to know this, and they'll test you on it. Is the patients taking any bisphosphonate, they have to be able to remain standing after they're done taking the medication for half an hour, at least half an hour afterwards, because it can cause significant acid reflux. So, esophageal ulceration is an adverse effect. Patients can get femoral fractures, esophageal cancer. They have to take it with a full glass of water. That's another thing the boards will ask in terms of patient teaching. Take it with a full glass of water, remain standing for half an hour afterwards. Musculoskeletal pain. And this is a rare side effect, but the boards can ask you about this, osteonecrosis of the jaw. Can lead to hyperparathyroidism and atrial fibrillation. What else I want to tell you about this drug? So generally speaking, all the side effects go together with all the bisphosphonates. And so again, risedronate, which is Actonel, and different bisphosphonates can be dosed either orally. Some can be like Boniva, ibandronate, is an oral preparation as well as an IV preparation. There are a number of different IV preparations for the bisphosphonates, but Actonel is one that is oral, and it has the same indications as alendronate. and same side effects: ocular problems, femoral fractures, musculoskeletal pain. Right? This drug, the bisphosphonates, it helps rebuild the bone because it's a structural analog of what's in the bone tissue, the pyrophosphate. And so as it's rebuilding the bone and keeping the bone together, patients develop pain. Ibanginate Boniva is a common drug. This is one that comes intravenously as well as orally, and the indications and uses are the same. All right. Adverse effects are the same. We generally will give these patients. Some of them can be given once a week. Some of these drugs can be given once a month. Some can be given once every 3 months, and there's one of them can be given even every 2 years. But you wouldn't be asked that on the boards. What you will be asked on the boards is the side effects, osteonecrosis of the jaw. So if they complain of jaw pain, you want to take that, seriously. If you want to test the effects of the or determine the effectiveness of the drug, we want to do a bone density scan, a DEXA scan, and what else? When these patients start these drugs, within 3 to 6 months, they increase their bone density by about 50%. So if you do a DEXA scan, if the patient does a DEXA scan, they'll be able to see improvement in their osteoporosis. So biggest side effects is esophagitis, esophageal ulceration, dyspepsia, or also esophageal ulceration, and AFib is what they like to test you on as well, and standing afterwards to prevent the GI effects, the esophagitis. Now, some of the studies that have been done on alendronate, for example, which is the first choice drug in this category, at one point they said, it's been linked to the increased risk of esophageal cancer because of the metaplasia that occurs in the esophagus due to this chronic reflux of GI content into the esophagus. And then there are other studies that say, no, not really. So, whether or not it causes cancer is still up in the air because there have been competing studies that show that disprove the other studies. Now, there are other drugs called SERMs, selective estrogen receptor modulators, and in this category is raloxifene, which is known as Evista, is structurally similar to estrogen and binds to estrogen receptors. These drugs are used to help decrease the bone demineralization in women who are postmenopausal due to, again, the decrease in the estrogen. So it pretty much preserves bone mineral density, and it also serves to decrease cholesterol. Now, this drug has been used to protect against certain types of cancer. It has effects in treating breast cancer. And there's another SERM that's used specifically for treating breast cancer when patients have certain types of breast cancers. They take this other drug, you're probably familiar with it, it's just used for they're on it for 5 years after they've had initial treatment for breast cancer, tamoxifen. This is a SERM that is used to reduce the risk of breast cancer and certain types of breast cancers. So these drugs are pretty much structurally similar to estrogen. and they function in multiple tissues, not just in some tissues. They function as agonists in some tissues and antagonists in other tissues, which are beneficial to some patients. So they can block the effects of estrogen, and estrogen antagonism will be beneficial to the patient, and they can also augment the effects of estrogen in patients who require augmentation of estrogen. So therapeutically, it can be used for osteoporosis and breast cancer. Adverse effects. Because of the effects of estrogen on blood clotting, it can lead to thromboembolic events such as DVTs, PEs, stroke, and it can lead to fetal harm due to the effects of blocking estrogen in the uterus as well as in the breast. So we're going to move on to chapter 76. Drugs for COPD and asthma. So there are two main pharmacologic agents or classes that we use to treat patients who have asthma and COPD. We use anti-inflammatory agents. And when we're giving anti-inflammatory agents to patients who present with asthma and COPD, there are different ways we use glucocorticoids. We can use it acutely for a patient who presents with an acute exacerbation, or we can use corticoids as long-term therapy, as inhaled. We try not to put patients on oral glucocorticoids because of the systemic effects, but that's not to say that if you give somebody inhaled glucocorticoids that they don't get systemic effects. They can still get systemic effects with inhaled glucocorticoids, but it's less than with systemic administration of oral steroids. And then we use bronchodilators, beta-2 agonists. So inhalation drug therapy is how we treat patients who have chronic obstructive lung disease. And there are three obvious advantages to treating patients with inhalation therapy. Therapeutic effects are enhanced because it's going directly into the area where it needs to go. Systemic effects are minimized, and relief of acute attacks is rapid. So there are three types of ways we can administer these drugs. We can use a meter dose inhaler, and meter dose inhaler, you've probably seen the pumps, right? They're measured in actuation. So when they're ordered, like it comes in 90 actuations per inhaler. So there are 90 pumps, 90 doses in there, 90 actuations. So for the albuterol. So the meter dose inhalers, what are these? It's pressurized. It's got a propellant in it that delivers a measured amount of drug per actuation, or per pressing of the canister in the little plastic that covers it. Now, usually when we prescribe these drugs, patients, you can prescribe one inhalation every 4 hours, every 6 hours, or two inhalations, depending on the drug. So 1 or 2 inhalations is how it's usually prescribed every X number of hours. Now, whenever the boards will ask you, whenever you have a patient who is getting an inhalation, 2 inhalations, what do you instruct the patient to do? You see patients all the time who take albuterol inhalers, and they need 2 puffs and they go puff puff right away. That's not the correct way to do it. The patient has to wait a minute in between each inhalation for the drug to be effectively absorbed into the respiratory tract. Otherwise, most of it will go into the environment and get trapped within the oropharyngeal space and get swallowed. All right, so wait a minute. And then there's also a whole technique to using metered dose inhalers. It's very much reliant on hand breath coordination. The person using it, they have to be able to initiate a breath as they press down on the canister and suck in the medication slowly. We tell the patients, try to do it over 10 seconds, not quick puff and inhale real quick. And slowly inhale it, with the lips tightening around the inhaler. So it requires, some people just don't have that kind of dexterity. Like older people may not have that dexterity, or some people may just not be able to do that, to coordinate the breath with the hand. So if you don't use them correctly, then you're just not going to get enough drug. I mean, even when used correctly, patient still only gets about 10% of the drug. But 80% of it gets, trapped in the oropharyngeal tissue, gets swallowed. All right, 10% goes into lungs and 10% go to the environment. So then if you don't use it properly, then you're really not getting much. So that's the metered dose inhalers, MDIs. Respimats are a little, before we move on to respmats, metered dose inhalers, if you want to improve the amount of drug that's going into the patient, you can use a spacer if they have, they don't have proper hand-mouth coordination. We can give them a spacer. And spacers help increase the amount of drug that the patient gets. It helps with the decrease of the deposition of the drug in the oropharyngeal tract. It helps decrease the swallowing of the drugs. It helps decrease the amount of drug that's on the mucous membranes that can lead to, if they're taking an inhaled steroid, it can lead to fungal infections. All right, so we tell the patients all the time when they're done, with the steroids, to rinse the mouth to get rid of the steroids off of the mucous membranes, because if they don't, they get fungal infections. And not only that, they end up getting the voice changes. They get dysphonia due to swelling of the vocal cords from chronic steroid being depositing on the vocal cords. Spacers helps eliminate those adverse effects and increase the amount of drug delivered to the patient. So spacers, they're like different ways spacers can come. They can come where, if you're not doing it properly, it makes a whistling sound it gives a whistling sound to alert you that you're not inhaling the drug properly. Maybe inhaling it too fast. Some people just inhale it very fast and it will whistle. And then another one that has like a one-way valve where you can take your time inhaling it, and nothing really gets lost if you don't inhale it properly. So it's a number of different methods by which the spacer works. Now, respimats are inhalers as well, and they are a little better than metered dose inhalers in terms of administration, or in terms of the patient getting enough drug. With respimats, patients get about 10% more drug than metered dose inhalers. And the reason that is because this drug it delivers the drug in a mist, and there's less fallout. With metered dose inhalers, the drug is not misty, and so there's more fallout with the drug. With respimats, the drug is a mist, and less goes into the environment, more goes into the body. Still, but most of the drug doesn't get into the patient. Only about 20% gets into the patient, but it's still better than the MDI. The dry powdered inhalers, these don't really require any kind of hand, mouth, or hand breath ordination. It's breath activated. It's a powdered form. The drug is in powdered form, and it's micronized powder. And so the patient there's a little lever that the patient moves back to activate the powder, and then they just put the device in the mouth and they just inhale it slowly. Breath activated doesn't require hand coordination with the breath. And then nebulizers, you've probably seen nebulizers or may have even used a nebulizer before. Nebulizers, it's a little device that you put the liquid medication into this little canister thing, this little holder, little cup, and it gets connected to the wall, can be connected to oxygen, and you turn the oxygen up to 6 liters, and the oxygen will cause this liquid, the albuterol or the ipratropium liquid, whatever liquid is in there, the mucomist, whatever liquid is in there, it will cause it to form into a mist. It nebulizes it and makes into a mist, and the patient can inhale it via a mouthpiece, or it can be given through a mask if the patient can't hold a mouthpiece. Sometimes the patients just put the mouthpiece on the bed with the medication still going. So especially kids, you can put a mask on them. Older people, you can put a mask on them. So the patient, it takes over time. It's not like an inhaler where you get it in right away. It takes several minutes to get the medication into the patient, but it is more effective than using an inhaler. Now with nebulizers, if a patient, for example, I just mentioned that you can give the drug nebulized using 6 liters of oxygen. That's how much we usually put up to. If a patient can't get 6 liters of oxygen, like we talked about patients who have COPD and there are CO2 retainers, you can't over-oxygenate them. When you're using a nebulizer and you have such a patient that run the risk of CO2 narcosis, then you can give the patient the nebulizer with compressed air. So you've probably seen them in the hospital too. You have these valves on the wall. One is, I don't know the color of it, but the one for compressed air is yellow. I think the one for oxygen is green. The one for compressed air is yellow. Okay, yellow. That's compressed air. No oxygen in it. So anti-inflammatory drugs, they're the foundation of asthma therapy, taken daily for long-term control. Principal anti-inflammatory drugs are glucocorticoids, for example, budesonide and fluticasone. Mechanism of action, considered the most effective anti-asthma drugs available: decrease synthesis and release of inflammatory mediators, reduce infiltration and activity of inflammatory cells, decrease edema of the airway mucosa that's associated with using drugs like albuterol. Albuterol can cause edema airway, and by giving glucocorticoids, it can decrease the inflammation. Usually administered by inhalation, but IV and oral routes are also options. Now, there's no difference in effectiveness using IV versus oral. It's just a difference in how quickly it works. IV works quicker than oral. So if we need a patient who's acutely exacerbated, we can give them IV, and then once they're stabilized, we can start them on oral glucocorticoid. So it's an inflammation suppressant. It reduces bronchial hyperactivity and decreases airway mucus production. So it blocks the actions of mast cells and histamine and all those inflammatory mediators that are stimulated by the release of histamine. May increase the number of bronchial beta-2 receptors and their responsiveness to beta-2 agonists. Glucocorticoids are used as prophylaxis of chronic asthma. Dosing must be on a fixed dose, not PRN. So albuterol, we can do PRN, but glucocorticoids, we can't do PRN. I teach my patients this all the time. Like, they'll tell me they have to remind them that their their inhaled glucocorticoid is not like an albuterol where when you feel short of breath, you grab it or you reach for it, and you have to take it every day in order for it to on a fixed schedule in order for it to be effective. But patients, they require teaching to know this. A lot of patients don't know this, and they're taking their Symbicort, taking the Symbicort PRN when they need to be on a fixed dose for it to work. And it's not used to abort an ongoing attack. That's what you have to teach them. You have to take it every day. It's preventative, it's not abortive. Inhaled use, first-line therapy for management of inflammatory component of asthma. Most patients with persistent asthma should use these drugs daily. Inhaled glucocorticoids are very effective and much safer than systemic glucocorticoids. Oral use, for patients with moderate to severe persistent asthma or management of acute exacerbations of asthma or COPD, patients may require oral use, but we try not to put these patients on oral corticoids because of the long-term effects. And so we keep them on it as briefly as possible. There's potential for toxicity and should be used only when symptoms cannot be controlled with safer medications like inhaled corticoids and inhaled beta-2 agonists. Treatment should be as brief as possible. Adverse effects of inhaled forms. The biggest adverse effects that you will probably get, all three of them, you need to know them. Dysphonia, oropharyngeal candidiasis, that's why they have to rinse the mouth, and adrenal suppression. Adrenal suppression, the adrenal gland will get suppressed by the negative feedback mechanism by which our body works for many of the hormones. And if we have exogenous steroids being given and the patient's systemic levels of steroids, glucocorticoids, is high, it's going to, via negative feedback, will shut down the hypothalamus from stimulating the anterior pituitary gland from releasing the adrenocorticotropin hormone to stimulate the adrenal gland to make glucocorticoids. And so there's adrenal suppression. Hence, this is, both questions. Once we're giving patients steroids, when we're giving patients steroids, we have to taper the steroids off. We can't just stop it because then they're going to go into an adrenal crisis and end up in cardiovascular collapse. So adrenal suppression, most often with oral therapy, less often with inhaled, although you can get some level of adrenal suppression with inhaled steroids. Now, and again, this comes from prolonged use. And depending on how long the patient has been on it will dictate how long the patient has to be tapered off of the steroids. Another thing the boards will test you on is if a patient is taking oral glucocorticoids in times of stress, we need more of cortisol. So our bodies will increase cortisol, that's a stress hormone, in times of stress. And it can be any kind of physiologic stress. And you get into a motorcycle accident, end up in the ICU, open heart surgery, pneumonia, sepsis, that's physiologic stress. And when patients are on chronic or long-term steroids, they get adrenal suppression and they're incapable of increasing their cortisol as needed for physiologic stress. And hence, there's no way for them to get that extra stress hormone release. And as providers, we have to know that the patient requires more exogenous steroids. So patients on chronic steroids in times of physiologic stress will require higher doses of their oral glucocorticoids, or we can give it to them IV if they're in a hospital setting. Glucocorticoids can slow growth in children and adolescents. However, they catch up. They do not decrease their adult height. It causes osteoporosis, increased risk of cataracts, and glaucoma. Adverse effects vary. It all depends on whether the patient is getting short-term or long-term treatment. With short-term treatment, the concern usually is in patients who are diabetics, raising the sugar. The concern is with long-term treatment. I've seen a patient the other day after putting her in steroids for like 3 days. She had significant edema. She had like +3 edema of her lower extremities, and it glucocorticoids increases salt retention and water retention, and so you may see patients even on short-term glucocorticoids are getting some side effects. They can also get gastrointestinal side effects, dyspepsia, due to the antiprostaglandin effects of the drug. Long-term therapy. Long-term therapy is associated with adrenal suppression, osteoporosis, hyperglycemia, peptic ulcer disease, growth suppression. Adrenal suppression, prolonged glucocorticoid use can decrease the ability of the adrenal cortex to produce glucocorticoids of its own, life-threatening at times, of severe physiologic stress, for example, surgery, trauma, or systemic infection. High levels of glucocorticoids are required to survive severe stress. Adrenal suppression prevents production of endogenous glucocorticoids, and patients must be given increased doses of oral or IV glucocorticoids in times of stress. If we don't do that, the patient can die from cardiovascular collapse. In terms of discontinuing drug, must be done slowly. Recovery of adrenal cortical function takes several months. Dosage of exogenous sources must be reduced gradually. During this time, patients, including those switched to inhaled glucocorticoids, must be given supplemental oral or IV glucocorticoids at times of stress. The other thing about giving patients who take oral steroids, when we give it to them, we want to mimic our body's own release of cortisol, our body's own release of cortisol. And so the recommendation is that they get 2/3 of their glucocorticoid dose in the morning and 1/3 in the evening. Oftentimes you don't see it that way. They just get, their once a day prednisone. But that's for the boards. 2/3 in the morning, 1/3 in the evening to mimic our body's own release of cortisol. Leukotriene modifiers, these are drugs that are used in the treatment of asthma and COPD. These drugs are used to suppress the inflammatory response by interfering with leukotriene, which when the patient has inflammation, it promotes smooth muscle constriction, blood vessel permeability, and inflammatory responses through direct action and recruitment of more inflammatory cells, such as eosinophils and basophils. So the leukotriene modifiers, they suppress the effects of trienes. In patients with asthma, leukotriene modifiers can reduce bronchoconstriction and inflammatory responses, such as edema and mucus secretion. So second-line agents, and we have 3 of them available. There's Xoluta, which is known as Zyflo, Zafirlocast, which is acrylate, and Montelukast, which is singular. Singular is the one that is probably most often prescribed, and it's used again for long-term to prevent exacerbation of asthma, basically. If a patient gets frequent asthma attacks, then starting them in this drug can help decrease the number of asthma attacks they get. Now, in terms of adverse effects, particularly young people, teenagers to young adults, they can have neuropsychiatric effects, so suicidal thinking and suicidal behavior. And again, this is in the young adult, late teens, young adults are more at risk for developing these adverse effects. But generally speaking, the most common side effects, and they're not very common, it's just GI in nature. Cromolyn is used for prophylaxis, not for quick relief. It suppresses inflammation, it's not a bronchodilator. It stabilizes the cell membrane of mast cells, thereby preventing release of histamine and other inflammatory mediators. It inhibits eosinophils, macrophages, and other inflammatory cells. Route of inhalation. Route is via inhalation, and it's given through nebulizers. Therapeutic use, it can be used to treat chronic asthma, exercise induced bronchospasm. Like I just had a patient who was training. She's young, she's in her 20s, she has asthma, and she's training. She's in police academy. She's training, and every time she goes to do her physical activity, she gets an asthma attack, and they had to, they told her she can't continue. So I gave her a nebulizer and told her to use the Cromolyn and albuterol the albuterol inhaler just before starting her exercise, and it was helpful to her. She was able to do her training. So this drug works great, but it's not for immediate. It's preventative. It doesn't abort. It's also used therapeutically to treat allergic rhinitis. Adverse effects is the safest of all anti-asthma medications. It can cause a cough and bronchospasm. Bronchodilators, they provide symptomatic relief but do not alter the underlying disease process, which is blocking or suppressing inflammation. In almost all cases, patients taking a bronchodilator should also be taking a corticoid for long-term suppression of inflammation. Principal bronchodilators are the beta-2 adrenergic agonists. The drug works by activating the beta-2 receptors in the smooth muscles of the lung, promoting bronchodilation and relieving bronchospasm. Beta-2 agonists, they have no inflammatory effects. So it's used in asthma and COPD, and there are different types of beta-2 adrenergic agonists. There are the SABAs and the LABAs, short-acting beta agonists, and then the LABAs are the long-acting beta agonists. And there are different indications for each one. Inhaled short-acting beta-2 agonists is SABAs, taken PRN to abort an ongoing attack. Exercise-induced bronchospasm taken before exercise to prevent an attack. It's like albuterol. Hospitalized patients undergoing a severe attack can get nebulized albuterol. And delivery with an MDI, delivery with an MDI, meter dose inhaler, in the outpatient setting may be maybe. Inhale long-acting beta-2 agonists, long-term control of patients who experience frequent attacks. Dosing is on a fixed schedule, not PRN. Effective in treating stable COPD. When used to treat asthma, must always be combined with a glucocorticoid. Now, this is the boards will test you on this here, so this is important. And not just for the boards, but for your life. Like, we cannot give a LABA to a patient who has asthma without a glucocorticoid. I'm going to repeat that. A patient who has asthma cannot get a LABA, a long-acting beta-2 agonist, without giving it together with a glucocorticoid. As a matter of fact, you won't see LABAs being sold without the combination of glucocorticoid. So they go sold together. And the reason for that is that it increases the risk of asthma-related deaths. Adverse effects of inhaled preparations. Patients get systemic effects. Sometimes you give a patient one albuterol treatment nebulized and they start tremoring, they get agitated, they're shaking, they get tachycardic, and if they have underlying cardiovascular disease, they may develop angina due to the increase in the sympathetic effects of the drug. Due to the increase of the sympathetic, the sympathetic response they get from using the drug increase heart. It's a beta adrenergic drug. It binds to the beta receptors. And beta 2 is specific for beta 2 receptors in the lungs, but in high enough doses, it has effects. All right, oral preparations, excessive doses can lead to angina, tachycardias, and tremors. All right, so long-term use of beta agonists is also tied to asthma-related deaths as well. Methylxanthines, this is a bronchodilator. You probably wouldn't see it as much anymore because it's not as safe as the other drugs, but they are still used, especially in the emergency room setting where a patient may have status asthmaticus. They may get intravenous aminophylline, but we used to give theophylline, way back in the day, and it's very rare that you'll see somebody on theophylline today. But theophylline is a sister of caffeine. It's a methylxanthine, which caffeine is. So it has those same symptoms that patients get when they drink too much coffee. All right, so theophylline, other methylxanthines include aminophylline, diphyllin. So these drugs are used, they're bronchodilators. They come as oral and intravenous preparations, like aminophylline comes as an intravenous preparation. Theophylline comes as an oral or IV preparation as well. And they have very narrow therapeutic index. And so we have to monitor levels of theophylline. Theophylline goes in that 10 to 20 box that we talked about last semester, 10 to 20 dacomycin, 10 to 20 creatinine, 10 to 20 Vivarin, 10 to 20 theophylline, 10 to 20 vanco. There's another 10 to 20, which I'm not remembering right now. But theophylline goes in there. Now, recent studies have shown that going all the way up to 20 has no more benefit in bronchodilation compared to being around a level of 8 or 9, which would be considered subtherapeutic, considering that 10 to 20 is considered therapeutic. But nowadays, the recommendation is try to keep them close to 10 as possible, and not all the way up to 20, because there's been no indication that keeping them in that range is beneficial. In fact, they may be harmful if they get a little higher. They may have significant side effects and neurologic sequelae. So, what does this drug do? It produces bronchodilation by relaxing smooth muscles of the bronchi. It has a narrow therapeutic index. Plasma levels 10 to 20. Oh, Dilantin. I just remembered the drug. Dilantin is in 10 to 20 box. Dilantin, theophylline, vancomycin, B1. Toxicity is related to theophylline levels. Now, the drug is usually given by mouth, but like I said, it also comes intravenously. Use in asthma and COPD. Oral theophylline is used to maintain therapy of chronic stable asthma, and theophylline is no longer recommended for COPD. So toxicity. So when usually when patients are in the therapeutic range, they don't have any kind of adverse effects. All right, so below 20, they're okay. Plasma levels between 20 to 5, they have nausea, vomiting, diarrhea, insomnia, restlessness. Right? But then they get serious adverse effects as the levels get higher. Above 30, they get dysrhythmias like VFib, they get convulsions, and these convulsions and these dysrhythmias, they don't respond to usual treatment. It's very hard to get them to stop convulsing or just get the ventricular fibrillation to stop. So, of course, if the patient is toxic, we need to stop the drug immediately. And if they have any in the stomach, we can give them activated charcoal with cathartic to get rid of it. And we can give them, for convulsions, we can give them a first-line agent for treating active seizures or non-stop seizures or status epilepticus, diazepam, or lorazepam. These are the 2 drugs that we use. Diazepam or lorazepam. And then for ventricular fibrillation, when they're fibrillating, we have to defibrillate them. And if they have ventricular tachycardia, we can give them lidocaine, antiarrhythmic. All right, so stop theophylline, activated charcoal, dysrhythmias, respond to lidocaine, IV diazepam, or lorazepam to control the seizures. So drug-drug interactions, caffeine, remember, is a methylxanthine, and it has the same properties as the theophylline. And so it can intensify the effects of theophylline that theophylline has on the heart and on the central nervous system. And not only that, caffeine, so theophylline is metabolized by hepatic enzymes, and theophylline can compete, caffeine can compete with theophylline for metabolism, and so it can cause theophylline levels to increase. Tobacco and marijuana can induce theophylline. They serve as inducers of enzymes to increase the clearance of the drug. Cimetidine, we know cimetidine is cement, all right? It's a CYP inhibitor, so it can increase the levels of theophylline. So we have to be very cognizant of giving these patients drugs that affect CYP enzymes when they're taking. Be cognizant of giving patients CYP enzyme drugs, both inducers and inhibitors when we're giving theophylline. All right. Fluoroquinolones can also increase the levels of theophylline because it interferes with the metabolism of the drug. Ipratropium is an anticholinergic agent that is used as an inhaler, can be nebulized, and when a patient is having an acute asthma attack, they can get this drug via nebulizer. Okay, when it's mixed with albuterol, it is called Duonab. All right, so it improves lung function by blocking muscarinic receptors in the bronchi, thereby reducing bronchoconstriction. Administered by inhalation to relieve bronchospasm. Therapeutic effects begin within 30 seconds, reach 50% of maximum in 3 minutes, and persist for about 6 hours. Adverse effects, it's anticholinergic, so it's going to cause dry mouth, irritate the pharynx, it can increase the pressure in the eyes, worsening glaucoma, and it has anticholinergic effects on the heart. So we have to be mindful of monitoring these patients for these adverse effects because it can lead to heart attack, stroke, and even death due to the extra work on the heart. Additionally, one of the things that can happen with ipratropium, which is not here, is that it can cause patients with asthma to get mucus plugging because it's so drying. It can dry up the mucus in the lungs and cause patients to get mucus plugging and impair ventilation. Tiotropium is the same thing, not approved for asthma, and it's pretty much the same. It's an anticholinergic agent. It's long-acting, and it usually comes in combination with a long-acting beta agonist and steroids. Adverse effects, dry mouth. All right, glucocorticoid and LABA combinations, There are multiple combinations that are sold. There's so many of them. It's so hard to keep up. There's a new one on the market now called Trilogy. Probably seen it on TV, and I was supposed to be the best of the best. But this was recently released for COPD, and then maybe last month or so they released an indication for asthma as well. But anyway, Advair is a combination of fluticasone, which is a inhaled corticosteroid, and salmeterol, which is long-acting beta agonist. Symbicort is a combination of budesonide and formoterol, and Dulera is mometasone and formoterol. These are LABAs, and these are steroids, and they're a combination. And they're indicated for long-term maintenance in adults and children. Is not recommended for short therapy. It's used for people who are reaching for that short-acting inhaler on a regular basis. Drugs for acute severe exacerbation. So this condition requires immediate attention, and the goal is to relieve the airway obstruction and fix correct hypoxemia and normalize lung function as quickly as possible. Initial therapy consists of giving the patient oxygen, giving the patient IV glucocorticoids like methylprednisolone or salmeterol to decrease the airway inflammation, give them a nebulized high-dose SABA, give them nebulized hypotropium, and that's given in the form of Duonet. 2-in-1, 2 nebulized agents. So a patient with asthma is prescribed albuterol, 2 puffs 3 times per day. The nurse should teach the patient to do what? This is albuterol SABA. Rinse the mouth after taking the prescribed dose. Take an extra dose if breathing is compromised. Wait 1 minute between puffs from the inhaler. Take adequate amounts of vitamin D and calcium. And Nicholas and Jacqueline say C, and C is correct. Patient has asthma and is taking triamcinolone. All right, not all of the steroids are indolone. Like budesonide doesn't indolone, but it's a steroid. So triamcinolone, so it tells you it's a steroid. It's inhaled. It's asthma port. What should the nurse do? Take the patient's pulse before administering the medication. Teach the patient to use a spacer to prevent fungal infection. Instruct the patient to use this drug to treat an acute attack. Encourage the patient to avoid weight-bearing activity. What is the right answer? What's the right answer for this? B, spacer to prevent fungal infection. Which information should the nurse include when teaching a patient about inhaled glucocorticoids? Inhaled glucocorticoids may have many significant adverse effects. The principal side effects of inhaled glucocorticoids include hypertension and weight gain. Use of a spacer can minimize side effects. Patients should rinse the mouth and gargle before administering inhaled glucocorticoids. Right answer is the right answer is right. So it's a little tricky question. Inhaled glucocorticoids have less significant adverse effects than oral. Principal side effects of inhaled glucocorticoids include weight gain. That's oral. Patient should rinse the mouth and gargle before administering and no after. And using a spacer can minimize the side effects of dysphonia and oral candidiasis. So answer is C. Which of the following is not a serious adverse effects of long-term glucocorticoid therapy? Adrenal suppression, osteoporosis, hypoglycemia, peptic ulcer disease. The right answer is, in the interest of time, I'm going to move forward, hypoglycemia. Miguel, nothing C for this one. Hypoglycemia. All right, it causes hyperglycemia. 1 second.
Professor, while you're pulling up the next slide, can you just repeat how methylxanthine interacts with tobacco and marijuana?
It it increases the metabolism of the drug. So it decreases the effectiveness.
Thank you.
You're welcome. All right, so drugs for allergic rhinitis, and then the other one is let's do peptic ulcer disease, and then we'll do rhinitis next week because that's nothing. All right, so peptic ulcer disease. All right, so the goal of drug therapy is to alleviate symptoms, promote healing, prevent complications, prevent recurrence of ulcers. Drugs do not alter the disease process, they create conditions conducive to healing. So there are a number of different drugs that we use. I just want to make sure we're recording. Okay, so we can use antibacterial agents, we can use anti-secretory agents, mucosal protectants, anti-secretory agents that enhance mucosal defenses, like Cytotec and antacids. So 3 ways anti-ulcer drugs work. We can use antibiotics when the patient has H. pylori to treat the infection. We can use drugs that reduce gastric acidity, like misoprostol, which is Cytotec, an anti-secretory, which is an anti-secretory agent, and other anti-secretory agents. Enhance mucosal defenses like misoprostol and sucralfate. So in terms of drug selection, it all depends on the patient, what other drugs the patients might be taking. So whatever the case is, if the patient has H. pylori, it needs to be treated when they develop ulcers. And even if they don't have ulcers, we still treat them because we want to prevent them from getting ulcers because H. pylori is tied to chronic peptic ulcer disease. It's the reason people get peptic ulcer disease. So antibiotics should be given to all patients with gastric or duodenal ulcers and documented H. pylori infection. And they can get an anti-secretory agent when we are treating them for H. pylori. Usually it's 2 antibiotics and a proton pump inhibitor. NSAIDs-induced ulcers we can prophylax, and there are people who are high risk for developing NSAID-induced ulcers from patients who are over 60, people who have a history of ulcers, people in high-dose NSAID therapy. And proton pump inhibitors are preferred for treating or prophylaxing for NSAIDs-induced ulcers. Misoprostol is also effective but can cause diarrhea. And misoprostol is only indicated for NSAID-induced ulcers. There's no other reason we should give misoprostol to any patient. So treatment of NSAID-induced ulcers, histamine blockers, and PPIs. So the PPIs, they end in O: omeprazole, ocimeprazole, pantoprazole. There are a bunch of ols and zoles that are, when you see the zoles, not the azole are antifungals. When you see the zole, lansoprazole, you know that's a PPI. If you see esomeprazole, you know that's a PPI. Pantoprazole, PPI. Antacid, sucralfate, and histamine 2 receptor blockers are not recommended. Discontinue NSAIDs if possible, and of course, we want to evaluate that the treatment. Sometimes what I tell my patients is that you may not get immediate relief if you have an ulcer. You start medications, and it may take some time before you feel relief. You may even be done with the treatment for the H. pylori and still have the gastric pain and discomfort even after doing 14 days of H. pylori treatment. So non-drug therapy diet, traditional ulcer diet does not accelerate healing. The ulcer diet is like avoiding spicy foods. Does not accelerate healing. Increasing dairy does not accelerate healing. No convincing evidence indicates that caffeinated beverages promote ulcers or delay healing. So we tell the patients, don't drink caffeine. Changing eating pattern to 5 or 6 small meals a day reduces pH fluctuations and may be helpful in creating a healing environment for an ulcer. We definitely want to tell the patients don't smoke and don't give the patient aspirin or any of the NSAIDs or alcohol that can delay healing. And of course, stress reduction. When we have stress, whether it's physiological or emotional, it can lead to the release of cortisol, which interferes with, which can worsen the monitor for relief of pain. Keep in mind cessation of pain and disappearance of ulcer rarely coincide. Pain may subside before complete healing or may continue even after healing. If we have a patient who has an ulcer, we can examine the gastroenterologist can do an EGD, an esophageal gastro, do an endoscopy to look at the ulcer site, and he can biopsy it and do an H. pylori test. Or even if the patient does not have an endoscopy done, we can check for H. pylori by checking serum antibodies. We can do a breath test to look for urease. We can do a stool H. pylori test. And those are non-invasive in nature. So serologic tests looking for antibodies to the H. pylori, stool test. Invasive is the EGD, biopsy of the tissue. So H. pylori treatment consists of a minimum of 2 antibiotics prescribed. Up to 3 may be used to reduce the risk of resistance developing. And these are the antibiotics that we use to treat H. pylori. So see here, bismuth compounds, clarithromycin, amoxicillin. Amoxicillin is very effective, but it has to be given with another antibiotic. So you'll see it come with amoxicillin, clarithromycin, for example, plus a PPI. Usually they can get it for 10 days, but 14 days is better, which, one would say, well, duh. But why would you want to give somebody 10 days of treatment? Well, patients can be very intolerant of these antibiotics. It's really causes severe abdominal discomfort, and sometimes the patient just can't handle it, taking the medications for more than, sometimes they come back after 2 days. I can't take this. So I have to switch around, maybe take the flu. Usually when they have GI upset, clarithromycin is what's causing it. And then and we just switch it out and give them metronidazole and remove the clarithromycin, and usually that does the trick. Bismuth compounds, they act topically. They were topically to destroy the H. pylori bacteria. All right, so clarithromycin, amoxicillin, bismuth, metronidazole, tetracycline, none is effective alone. If these drugs are used alone, the risk of resistance develops. Clarithromycin, Iaxin, suppresses growth of H. pylori, it inhibits protein synthesis. In the absence of resistance, treatment is highly effective. Unfortunately, rate of resistance is rising, exceeding 20% in some areas. Most common side effects, GI in nature. And then they have a metallic taste of the mouth. Some patients will report a metallic taste that is awful. But GI. Amoxicillin, H. pylori is highly sensitive to amoxicillin. Rate of resistance is low. All right, and again, kills the bacteria by disrupting the cell wall. Antibacterial activity is highest at a neutral pH and thus can be enhanced by reducing gastric acidity, and that's why we give it with an anti-secretory agent such as a PPI. Most common side effects, GI, diarrhea. Bismuth compounds, they act topically to disrupt the cell wall of H. pylori, causing lysis and death. Also may inhibit urease activity and may prevent H. pylori from adhering to the gastric surface. So this, you have to teach the patient, can impart a black, and it's harmless, discoloration to the tongue and stool. So we tell our patient to expect it. All right, but the issue is by this black discoloration occurring, it can interfere with somebody determining whether or not they're having a gastric bleed, which when a patient has melena in the upper GI tract bleed, and they get melena, the stool turns black as well. So it's it would be difficult if a patient did develop upper GI bleed to tell if it's GI bleed or the medication. Our long-term risk of, also risk of neurologic injury. Tetracycline is an inhibitor of bacterial protein synthesis, highly active against H. pylori. Resistance is rare. And of course, we can't use in pregnant women. We'll talk about this next week. Can't use in pregnant women and young children because they can stain the developing teeth. And it's permanent. Metronidazole is very effective against sensitive strains of H. pylori. Over 40% of strains are now resistant. The most common side effects are GI in nature, nausea and headache. Avoid alcohol. This is important because they can get a disulfiram reaction if you mix metronidazole with alcohol. So the goal of antibiotic regimens is to minimize emergence of resistance. Guidelines recommend using at least 2 antibiotics, preferably 3, and use a PPI is preferred in terms of anti-secretory agent. Eradication rates are good with a 10-day course and slightly better with a 14-day course. Histamine 2 receptor antagonists, these are the drugs that end in tidine, famotidine, ranitidine, all cimetidine. Okay, these are all over the counter. I think they just pulled Zantac off of the market recently. But they all pretty much work the same. Some, and you see one of them has anti-androgen effects, and then the others do not. So that's mainly the difference. So first choice drugs for treating gastric and duodenal ulcers, they promote healing by suppressing secretion of gastric acid. They're one of the first line agents. All 4 equally effective. Serious side effects are uncommon. Cimetidine, absorption is slowed if taken with meals. Crosses the blood-brain barrier with difficulty. However, it still may cause some central nervous system side effects. Now, the biggest thing we've been talking about cimetidine all semester long is that it's a CYP inhibitor. Okay, therapeutic uses: GERD, ulcers, aspiration pneumonia, heartburn, indigestion, sour stomach. So adverse effects. Cimetidine has anti-androgenic effects. So we have to take that into consideration when we are prescribing this for our male patients. All right, why? Because cimetidine will bind to androgen receptors and block the receptors. And so patients will have signs of anti-androgen, such as gynecomastia, reduced sex drive. They may even get erectile dysfunction. Central nervous system effects most happen in older people, not younger people. Patients may become somnolent or confused, may even hallucinate, and even may even go to the opposite end where they get CNS excitation and may even get seizures. Pneumonia. Pneumonia happens as a side effect of many of these anti-secretory agents. All right, because when gastric acidity is reduced, it promotes bacterial colonization in the respiratory tract, and so patients can develop pneumonia. IV bolus can cause hypotension and dysrhythmias, especially if it's pushed quickly. Drug interactions, we know we've been talking about the drug interactions because of the inhibition of the enzymes that metabolize warfarin. It can increase the levels of warfarin significantly. And all of these drugs here, phenytoin, warfarin, theophylline, all of these drugs have very narrow therapeutic indices. And so we have to be very careful in dosing these patients. The dosage would have to be reduced because cimetidine increases their levels. Antacids can reduce the absorption of cimetidine, and they should be given at least an hour apart. Famotidine is Pepcid, action similar to those of ranitidine, which is Zantac, which was just pulled off of the market. All right, and then the same therapeutic uses. Again, it's over the counter. Cimetidine is over the counter. Adverse effects. It has no anti-angiogenic effects because it does not bind to androgen receptors. And again, risk of pneumonia. Proton pump inhibitors. They're the most effective drugs for suppressing secretion of gastric acid. It can be used short term, it can be used long term for treatment of GERD and ulcers. Generally well tolerated. There's some things that you have to know for the boards in terms of side effects. All right. Pathologic fractures due to decrease in bone mineralization, risk of pneumonia, risk of acid rebound, and possibly intestinal infection with C. diff. Okay. They all are equally efficacious. Omeprazole, first PPI, inhibits gastric secretion, used for short-term and long-term therapy. Ulcer prophylaxis is indicated only for patients in intensive care units. So when you see patients in the ICU, back in the day, anybody who got admitted, they got a PPI or they got a histamine antagonist, a H2 blocker, for prophylaxis for stress ulcers. But only patients who are really sick with physiologic stress, like those in the ICU, is it indicated for to prevent stress ulcers. So PPIs are used to prevent stress ulcers. Adverse effects, usually inconsequential with short-term use, which is true, but long-term effects, hypomagnesemia is another long-term effect that people experience when they take the PPIs. You can get fractures, pneumonia, rebound, acid hypersecretion, C. diff, and it's weakly linked to gastric cancer. Other anti-ulcer drugs, sucralfate, which is Carafate, Cytotec, which is misoprostol, and antacids. Sucralfate is a drug that's given 4 times a day. It's given before meals and before you go to sleep. Basically, it just puts a protective barrier in the ulcer crater to protect it from the acidic environment of the GI tract and helps healing. Adverse effects, constipation, about 2% of patients. Drug interactions are minimal, and antacids may interfere with the effects of sucralfate. Misoprostol or Cytotec is only used for NSAID, long-term NSAID, people who have long-term NSAIDs to prevent gastric ulcers. That's the only indication for it. It's category X. It can stimulate uterine contractions and it does lead to spontaneous abortions if a person who's pregnant uses it. In some countries, it's sold as an abortion pill. Antacids, they react with gastric acid to produce neutral salts or salts of low acidity. Reduce destruction of gut wall by neutralizing acid. May also enhance mucosal protection by stimulating production of prostaglandins. Except for sodium bicarbonate, which is absorbed systemically, antacids do not alter systemic pH. And of course, we have to use a caution with patients who have renal impairment because antacids come with things, with ionic compounds or ionic products that can rise in the bloodstream, like magnesium and sodium and aluminum. So antacids, depending on which ones we use, when we use the aluminum-based antacids, it causes constipation. When we use the magnesium-based antacids, it causes causes diarrhea, and antacids can lead to sodium loading, so we have to be very careful giving it to patients with CHF. Drug-drug interactions. All right, cimetidine. Ranitidine pretty much has the same properties as cimetidine, and sucralfate, it will decrease the absorption of the antacids. So these are the antacid families here: aluminum, magnesium, calcium, sodium compounds. Milk of magnesia. Generally in the hospital, when we use milk of magnesia, we're using it to treat constipation, all right, because it's magnesium based and it causes diarrhea. And so we generally don't use milk of magnesia for treatment of dyspepsia or acid reflux. We generally use it for its effects on causing loose bowels. So it's a rapid acting, high acid neutralizing capacity. It produces long lasting effects, an antacid of choice. Most prominent adverse effects is diarrhea, and it's usually taken in combination with aluminum hydroxide to prevent the diarrhea. Avoided in patients with undiagnosed abdominal pain. That's something the boards may test you on. Like, you can't give stuff to fix abdominal pain if you don't know why the patient is having abdominal pain. Frequently used as laxatives, and we want to use it in caution with patients with renal failure because they can't clear magnesium. They end up with hypomagnesemia. Aluminum hydroxide has a low acid neutralizing capacity, is slow acting. Effects have long duration, and it's rarely used alone because it's constipating. Widely used in combination with magnesium hydroxide, MOM, milk of magnesia. And it has significant amounts of sodium and can lead to exacerbation of heart failure and fluid retention and swelling, causes constipation, and it has drug-drug interaction with tetracyclines in terms of decreasing the absorption of tetracyclines. All right. And has interaction, again, it interferes with the absorption of drugs. And so we have to be very careful giving aluminum hydroxide with their drugs. Calcium carbonate, this is known as TUMS. Rapid acting, high acid neutralizing capacity, effects have long duration. It can lead to acid rebound, and the principal adverse effect is constipation, which can be overcome by giving it with milk of magnesia. Side effects, eructation, which is belching, and it tastes like chalk. Sodium bicarb can cause systemic alkalosis because it's absorbed systemically, and it's used in patients who, for example, have metabolic acidosis. You'll see it used in patients, for example, who have renal disease and have some level of metabolic acidosis. However, it's also used for treating elevating urinary pH to promote excretion of acidic drugs after overdose, like aspirin. Inappropriate for treating peptic ulcer disease. It's got a high sodium content and can cause alkalosis. Can exacerbate hypertension and heart failure. Combo packs, this is for H. pylori. These are different antibiotics. There are 2 antibiotics in here and a PPI, 2 antibiotics in here, PPI, 2 antibiotics in here and a PPI. It all depends on what we're looking for. For example, PrevPack, if you have a patient who this has amoxicillin in it. If you have a patient who has penicillin allergy, we can't give them PrevPack because it has amoxicillin in it. So we can give them Pylera. Pylera has tetracycline in it and metronidazole, and it does not have amoxicillin, it has bismuth. So it all depends on the patient's allergies, what medications the patient might be taking that may have an interaction, for example, with these antibiotics. All right, so I'll let you go here, and we will pick up next week where we left off today. Any questions? Okay, in terms of the exam, I'm going to post the exam by 7 p.m. tonight, and I will keep it open until next Tuesday night.